Hello everyone and welcome to the 3D Systems webinar. My name is Tal Avziz and I'm the Senior Product Manager for the ANGIO Mentor Simulator, and I will be the moderator for today's webinar. Also with me here today is Iris Ariel, our Product Manager for this line of products. And in today's webinar, our speaker, Dr. Thomas Masaryk, will discuss recent studies, patient selection, and stroke treatment pathway in his hospital. In the second part of the webinar, we will show a demonstration of the stroke intervention on our ANGIO Mentor Suite simulator. And at the end of the session, we will have time to answer some of your questions. If there will be any questions that will not be answered during the webinar, we will reply them in an email at the end of the session. Now, a short explanation of how to participate in the webinar. On your right-hand side of the screen, you have a box where you can type and send me your questions during the webinar. As you can see, where my cursor here now. And also during the webinar, we will ask poll questions. So please answer them by clicking the relevant answer on your screen. Some tips for improved user experience. So first of all, we recommend to close all open windows on your desktop. And for improved video display, just click on the full screen button, which is the blue one at the right side of your screen. Now a few words about 3D Systems. 3D Systems is the inventor of 3D printing, and today it's the leading provider of printers, software, and services that help you take advantage of this amazing technology. 3D Systems Healthcare Division is on the front line of surgical planning and personalized medical solutions for almost 2 decades now, with over 200 employees worldwide. Now, our ANGIO Mentor virtual reality simulator, as part of this healthcare division, is used for the purpose of training and preoperative planning of endovascular procedure. Today, we support more than 25 different procedures for individual and team training, and over 300 cases used for training of multiple disciplines. Now, for our first poll question, we would like to know what is your specialty. So please take your time and select one of the answers below. Okay, so we have a variety of participants in the audience, and looks like most of you are not part of the neuroradiology community, but coming from other disciplines. And I think this will also be very interesting for our speaker. So I'm honored to present our guest speaker today, Dr. Thomas Masaryk. With 30 years of experience in neurovascular procedures and 17 years of experience in stroke intervention, Dr. Masaryk is the chairman of diagnostic radiology at the Cleveland Clinic Foundation, professor of radiology at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University, and the fellowship director of endovascular surgical neuroradiology at the Cleveland Clinic Neurological Institute Center. Please, Dr. Masaryk.
Thank you, Tal. I just want to let everyone know that I have no financial interest to disclose. I'm just simply a poor neuroradiologist, and I have no conflicts to report with this presentation either. I should also be honest in acknowledging that I just dodged a bullet. There was an acute stroke that just landed in the helicopter about 20 minutes ago, and fortunately one of my colleagues was able to take over the case. So I'll be able to do the webinar. So, second question. The kind of stroke cases that are currently being seen and treated by the audience, could you indicate what your current level of experience or volume is at your institution? Okay, good. Somebody's got tremendous experience with over 200 cases. But that's not surprising. The jump from endovascular procedures for aneurysms, AVMs, and so on to acute stroke requires a whole different infrastructure, and it's not surprising that people are just starting to do this with any great enthusiasm. So, some background. Stroke in the United States is still a leading cause of death and disability. 1 in 5 women, 1 in 6 men will have a stroke in their lifetime. The annual incidence is over 750,000 people, and the direct and indirect costs, in terms of the direct cost of in-hospital management as well as subsequent rehabilitation and care, is exorbitant. So the big change in the way, in the course of my career, I started practicing in 1986, with the way people thought of stroke was in 1999 with the publication of the NINDS trial and the FDA approval of intravenous TPA for acute stroke. And there were some naysayers that, indicated that, well, it was only maybe 10 or 15% improvement in outcome, but that was basically compared to doing absolutely nothing. And on the heels of the NINDS trial, there were several realizations about the kind of strokes that IVTPA worked for, and also quite a bit of interest in seeing if there were other ways of addressing those strokes that IVTPA did not work for. But a couple of the key elements that I think we gloss over that really have impacted care beyond thinking what you could do for an acute stroke. The first is the ability to quantify a stroke in a numeric scale. Instead of going through a long description of a neurologic exam, what the gaze is, whether they're hemiparetic in the arm or the leg or what have you, with the recitation of a simple number, you know right away how severe that stroke is. It's the culmination of a pretty complete neurologic exam, but it gives you a numeric value that lets you know, okay, less than 8, maybe not so bad, or a mild to moderate stroke. Over 10, potentially this could be a disaster. And I think the use of this scale, and everyone knowing how to use the scale and implement it and what it means, is critical. The second thing that came out in the course of trials after the NINDS trial was the TICI score, named after the TIMI score used in many of the acute myocardial infarction trials and trying to revascularize the coronaries. This was simply adapted to give a score for the angiographic recanalization of the vessels in the brain. And in particular, recanalization to the level of 2B or 3, partial perfusion greater than half of the occluded territory, or complete reperfusion of the distal territory. There's some very strong indications that that correlates very strongly with better outcomes. And finally, the use of a common metric by which clinical trials could be done, and very quickly without a lot of arduous testing, at least giving some common idea on a scale of 0 to 6 of how severely a person is disabled. Generally speaking, a Rankin score of 0 to 2, no symptoms or slight disability but able to look after their own affairs, those are considered reasonable quality of life. Rankin score of 3 or higher, obviously death not considered so good, very bad. But this has been adopted as typically the primary outcomes measure for many of the subsequent strokes trials which have appeared in the last 20 years since the NINDS trial was published. And of course, the goal, if you can see my cursor hopefully here, with no perfusion at the time of the original occlusion, this is at 5.5 hours, one can see on this diffusion scan the beginnings of an early infarct in the lenticular striate distribution of the right middle cerebral artery. And the perfusion scan shows a much larger area of low flow and what's known as the ischemic penumbra, the area of brain at risk. And left untreated, you can see after 3 days that that penumbra has likewise gone on to infarct. Here's a similar patient seen at 4.5 hours where they've got a relatively small diffusion-weighted infarct and then a patchy area of poorly perfused but still viable brain around it. And if they're reperfused, you can see that at 3 days, the infarct has been fairly limited. And this has always been the rationale for acute stroke treatment. Now, the other very important thing that came out of the IV trials, both the NINDS trial, but as well as the ECAS trial and the Atlantis trials, is the fact that the timing of getting the patients treated really makes a difference. And this graph is meant to depict that, which shows the odds ratio of no treatment versus treatment with IV TPA versus time, starting at 60 minutes and extending out here. And you can see that at 4 hours, the odds ratio is still slightly positive. But when you get out to 5 hours, you start to get to an odds ratio of close to 1-to-1, and IV TPA is no longer successful. But this really shows you that it's a curve that continues on the downslope, and the faster you can treat people, certainly the better off they're going to do. And it was in part this model that led to subsequent trials emphasizing what we here call the drip and ship, meaning make the diagnosis, make sure they're not bleeding, drip the IV TPA in, and then ship them via ambulance, helicopter, whatever means of transportation necessary to some place where something more could be done. Well, in what kind of cases would more could be done be necessary? If you look at IV TPA for all comers, you see that only about 31% of strokes recanalize. And certainly if you, in an MCA occlusion, if you have an M2 branch occlusion, it's much higher, 40%. And as you march your way back towards the heart with larger and larger vessels and larger occlusions to the level of the carotid artery, that when you get that level of occlusion, it's not just that you don't have as much opportunity for collateral support from PL collaterals from the anterior or the posterior cerebral artery to the middle cerebral territory, but you also have a much bigger clot burden. And those cases are not going to recanalize, and the outcomes are persistently poor. This just looks at spontaneous reperfusion initially and at 24 hours. Here's reperfusion initially and at 24 hours with IV TPA, and here's reperfusion with IA TPA as well as mechanical thrombectomy. And what you can see here is that several of these, much of this data indicates that the recanalization rate is better with some other efforts over and above IV TPA, particularly with the mechanical thrombectomy devices. And that good outcomes, at least in some of the trials, back in 2007, non-randomized trials, suggested that, well, there may be a better way than just IV TPA. So the rationale for intra-arterial therapy is 70% of patients present with stroke have some sort of cerebral occlusion. If you're at a primary stroke center, you may be as lucky enough to have an IV TPA administration rate within the 3 or 4.5 hour window of close to 15 or 20%. But in community hospitals, the rate of giving IV TPA for stroke is only about a few percentages of all the patients that present. And although it's effective, again, for smaller branch occlusions, in 57 to 58% of the patients given IV TPA in the NINDS study, they became dependent or died. So there are a lot of large vessel, big, nasty strokes that are left untreated with IV TPA, and hence the rationale for intra-arterial therapy. So people embarked on this idea of intra-arterial therapy very enthusiastically, and in 2013, 3 studies were published that just crushed the spirit of the authors of those trials, as well as anybody who's been doing endovascular treatment for stroke. I first got involved in the late 90s, shortly after the NINDS trial, where we were giving intra-arterial thrombolytic therapy in the PROACT trial. And we saw a few patients that did miraculously well, but we also saw a lot of patients that didn't do so well. And when you did a randomized trial and the results came out in 2013, the IMS-3 trial, the MR-Rescue trial, and the Synthesis trial, all published in the very prestigious New England Journal of Medicine, the risk was not increased. There wasn't any increased risk of intracranial hemorrhage or statistically significant increased risk of intracranial hemorrhage doing these maneuvers, but there also was not significant benefit. And again, everyone was just crushed. And if you just sort of summarize the interpretation of these 3 trials, that at some level, they were a little atypical to what was being done at the time they came into print. So by that time, especially in the IMS-3 trial and some of the other trials, there were a variety of devices, techniques that are no longer in use. And at least in one of the trials, the outcome measure was very strict. It was a Rankin score of 0 or 1. Many of the other trials, both before and since then, use a Rankin score of 0 to 2, so a little broader, less restrictive definition of what is a reasonable quality of life after stroke. But one of the other conclusions was that IV TPA is effective, should be offered to eligible patients, but again, as quickly as possible. And that has certainly come through in all the trials, that the faster you treat, the better patients do. Now, what really was a game changer at the time that those trials were published was the recent introduction to the marketplace of stent retrievers. And these devices are stents essentially mounted on a stylet, which are not meant to be deployed and left in the body. They are deployed across the thrombus, and as the thrombus engages this wire mesh through the cells of the stent, it becomes caught there, and then you withdraw it and can bring the clot out. And as I said, as those 3 trials came out, these were already in use. They hadn't been introduced at the time that those trials started, so there was a very low adoption rate in those trials, and were really not included in their results. But people kept saying, oh my gosh, these things work so much better. I can remember telling my colleagues this, that these stent retrievers seem to be just all the difference in the world, to the point that in the first few times you tried them, you really didn't believe that this was going to keep up. And in fact, the ability to actually mechanically reopen the device has turned out to be a pretty regular occurrence. The question is, did you get the patient in time? That is always the question. So this is just a typical example of a left MCA occlusion. You can see the M1 cutoff here, and this is just a typical appearance after a single placement of a stent retriever. The clot just sort of seems to come right out. So then subsequently, in the early part of this year, a flurry of trials, all using the stent retrievers, appeared. Again, all in the very reputable New England Journal of Medicine. The ESCAPE, Extend IA, Revascat, Mr. Clean, and Swift Prime all came out, and to varying degrees demonstrated that these devices did, in fact, improve patient outcomes. So let's look at those quickly. The first is the ESCAPE trial done at 22 centers in Canada, the US, Korea, the UK. 316 randomized patients. Intervention was mechanical thrombolysis with an approved device. and the control study was guideline-based IV TPA in under 4.5 hours. And again, acute strokes greater than 18, last known well in less than 12 hours. Last known well, in addition to the NINDS, the Rankin score, and the TICI score, is really one of these key things that you need to establish early on in the stroke. Aspect score is essentially the amount of infarction seen on the presenting CT scan. We'll get to that in a little bit. And good functional baseline status. They also was one of the only trials of the ones that I just mentioned that tried to gauge peel collateral on CTA. They didn't do perfusion study per se, but they looked at CT peel collateral. So here's an example here of reasonably good collaterals, a small M1, M2 occlusion, and you can see in the later phases of the CTA pretty good collateral flow into the left middle cerebral territory. Here we see poor collaterals in the lower left in the right MCA, and you can see even on the delayed scans there is just not much contrast getting there. So they use that to help stratify patients a little bit. You can see things like age, sex, baseline NIH, presence of hypertension, diabetes, atrial fibrillation. I would point out that the atrial fibrillation rate of 35 to 40%, very common. Many of these patients who present with carotid or M1 occlusions or even occasionally basilar artery occlusions, they are in atrial fibrillation, and these occlusions are not in situ thrombosis, they're cardioembolic events. But an NIH score of 16 or 17 as a median, that is a pretty severe stroke. You can see the recanalization rates with control versus intervention, ipsilateral cervical carotid. This shows where the occlusions were, excuse me, not the recanalization rates. The occlusions are almost identical. About a quarter of patients had carotid occlusions, 3/4 had M1 or M2, and a very small percentage had distal branch occlusions. Many of these likely lysed with IV TPA. And here you can see this just shows the time parameters documenting how long it took to get TPA, how long it took to get randomized, how long it took to get the CT scan, how long it took from the CT scan to get the groin puncture and to get mechanical thrombectomy device in place. And again, the vast majority of these patients were treated with stent retrievers. And you can see that an almost equal percentage, 72.4%, had 2B3 reperfusion, really pretty good, whereas by comparison the control group had reperfusion less than half of that. And if you look at the modified Rankin scale at 90 days, which was the primary outcome, again, it's not quite 2 to 1, but pretty close. A little over half of patients that had thrombectomy did have a very nice clinical outcome. And this is just the typical shift analysis, which shows the difference between intervention versus control and the shift in Rankin 0, 1, and 2, and the greater percentages with intervention. And again, this just shows complications, not statistically significant. Notice that with a much smaller percentage of large MCA strokes, the death rate was quite a bit less in the intervention group. So the second trial was the Extend-IA. This was performed in Australia, in New Zealand. Much smaller study, 70 randomized patients, stent retriever plus IV TPA versus IV TPA alone. Now the one thing to notice about the Extend-IA trial is that their primary endpoint was not the Rankin score. Their primary endpoint was a drop in the NIH stroke score by 8 points in the first 24 hours after reperfusion, or to 0 or 1 by day 3. And my personal comment is that that is a whopping drop, a big drop in NIH stroke score, and I would presume that that would be a pretty high bar to meet. So if you look at that, 80% of patients with TPA and stent retrievers did actually, in fact, get that kind of a response, which I find quite remarkable, quite honestly, almost unbelievable. That's such a good response. And if you look at the secondary outcome of the modified Rankin at 90 days, again, 71 versus 40%, so not really too different from the ESCAPE trial. And the shift analysis, again, from Rankin 0 to 1 to 2 shows much better percentages of reasonable outcome. Okay, one of the last trials, Revascat, 4 centers in Spain, 206 patients within 8 hours. Stroke patients 18 to 80 years of age. They had to be in good clinical condition pre-stroke and have a baseline score of greater than 6. Again, they should have a limited infarct or an aspect score of 7 or greater, or if you're using diffusion imaging, a 6. And again, they were randomized stent triever versus IV TPA within 4.5 hours. And again, very similar kinds of time points to what we saw with the ESCAPE trial, which is very, very good, less than 2 hours administration of IV TPA from last known well. A little bit of time to get randomized, but the time they obviously were taking patients right to the angio suite and then waiting to get randomized because they got puncture in very short order after randomization and the reperfusion just a little over an hour after that. Revascularization with intervention, slightly less than the other trials, but still very good at 66%. And here the 90-day Rankin is not quite as good, but still substantially better than control. And the odds ratio is still greater than 2 to 1 for these large vessel occlusions. And again, just the shift analysis for 0, 1, and Rankin of 2. And finally, Mr. Clean. I think we have 2 more trials left to just very similar to the other trials, but this one is remarkable for the number of patients. 500 patients within 6 hours at 16 centers in the Netherlands. The NIH score, the threshold didn't have to be that great. Randomized 1-to-1 endovascular mechanical thrombolysis with an approved device, i.e. stent triever, versus standard of care. And again, they saw these patients very quickly. In less than an hour and a half, they got IV TPA. They were randomized at about the same time as the Revascat trial, about 200 minutes. Groin puncture at just over 4 hours and reperfusion a little past that. And you can see the device breakdown again, most of them stent trievers. If you look at intervention, the recanalization rate, again, close to 60%, a little bit less than some of the other trials. But again, also, this is 500 patients. Now, the odds ratios here are about the same, about 1.7%. But the overall percentages a little bit less, which I think speaks to the fact that these large vessel occlusions inherently do not do well with IV TPA. So I don't see this as a huge negative. I think it's just a recognition that these are just horrible strokes and patients are going to be severely, severely impaired or die. Again, here's the Rankin score shift analysis from control to intervention. They had no patients in the control group who were Rankin 0 at 90 days. And finally, the SWIFT Prime trial. We were enrollers in this trial. 39 centers in the U.S. and Europe, 196 patients, pre-stroke status of a Rankin less than 1, aspect score on the initial CT scan greater than or equal to 6. This sort of corresponds to the NINDS threshold on their presenting CT scan for IV TPA of completed stroke in less than 1/3 of the vascular territory. That's essentially what that means. Baseline NIH at randomization had to be pretty significant, 8 to 29, and TPA within 4.5 hours. Again, this just shows where the occlusions were. The vast majority of these are M1 or M2, and most of these are cardioembolic occlusions. Look at this, the recanalization rate, 2B3A with the stent triever arm, just under 90%, and almost 70% of those completely revascularized. an odds ratio of just under 3, one of the better ones of any of the trials. And again, 60% of the patients were ranking 0 or 2 at 90 days. That's pretty doggone good. And 35%, or just under 36% for the control group. Again, the shift analysis, you'll see these graphs in virtually every one of these presentations. So this is just a summary that I included for here. If you're interested after the talk, you can review the different trials. But this speaks to the fact that now we've gone from 2013, the 3 trials in the New England Journal, to these 5 trials, which have completely turned the world on its head for the treatment of acute stroke, and in particular, the worst strokes available. And I don't know, some of you in the States or Canada, I don't know if anyone else saw this, but the New York Times is a very popular newspaper in the United States. And on a Sunday, less than a month ago, there was this article published about acute intervention and acute treatment for heart attacks, indicating that racing the clock, saving the heart, faster care helps death rate plunge 38%. And they talked about how remarkable it's been to get patients into percutaneous coronary intervention in less than an hour. Now, as a neuroperson, I would argue that the heart is a much less eloquent organ than the brain, and if you don't get blood to the brain fast enough, the consequences are going to be a lot more severe. But buried back on the back pages of this article was the following. The same article, the quote was, "The improvements in treatment have spilled over into the care of stroke victims. Neurologists watch with envy as cardiologists slash their times. For strokes too, the time it takes to be treated within clot-dissolving TPA is of the essence. Time is brain, neurologists say. They began to copy cardiologists." And so we have, but again, since January in the appearance of this trial, the model until then was always IV TPA and keep your fingers crossed. Now it's figure out how bad is the stroke, how much of the stroke is completed, and do you need to get that patient to the cath lab? And that was followed by this quote which says, "Seeing that someone else could do it was remarkably motivating and a little bit competitive," said Dr. Lee Schwan, the Chief of Stroke Services at Mass General. "If they can do it, why can't we? The payoff from these changes has been breathtaking." And I believe, in fact, that that's exactly correct, and we are in the midst of a big change in the way strokes are to be treated. So, again, we're sort of emphasizing for the purposes of this webinar the fact of the procedure, but in point of fact, getting the patients in, getting them triaged, getting the language down, the NIH stroke scale, last known one, everybody communicating all these things efficiently, quickly, that is another piece of it that really takes a lot of organization. So you need to have good pre-hospital triage, hospital triage with imaging to determine whether or not there's a bleed or maybe even a metastases as opposed to a bland stroke. Treatment of blood pressure, glucose, very important. They got to get the IV TPA. As I said previously, only about a few percentage of patients at a community hospital get IV TPA for an acute stroke. And then if they have a really bad stroke and you've got them soon enough, you need to know where to get them to get endovascular treatment. And beyond all that, then they need supportive care, rehab, risk modification, what have you. And what we've sort of at least gotten to the point, we have these steps all plotted out into what we here in Cleveland call a care path. What we do is we, again, because this is so time-based, we measure this. We measure when did they get seen, when did they get their CT, when did they get their TPA, when did they get triage, when was the needle stick time in the angio suite, when did they get recanalization, on and on and on and on. And in fact, to the Joint Commission, these things are going to be benchmarked and publicly available to the public to see how different stroke systems compare. So the Joint Commission of Hospital Accreditation Organization in the United States stratifies stroke centers. So you have an affiliated acute stroke regional hospital, which basically has some way of getting an acute scan in their emergency room. either in person 20 or via telemedicine, and we do this with several small hospitals out in rural communities in Southeast Ohio. We have a presence in their emergency room that they can do a stroke score, they can get the images immediately from the scanner and make a decision and help the emergency room doctor to determine whether or not to give IV-TPA. And then those patients are shipped to primary stroke centers, and primary stroke centers have all those other capabilities, plus enhanced imaging capability, and some of them may even have the ability to do acute stroke interventions in the form of thrombectomy. And finally, comprehensive stroke centers are large tertiary or quaternary centers that have every capability at your disposal 24/7. But truly one of the bigger differences is in the comprehensive stroke centers, more expertise in cerebrovascular neurosurgery. Now this is just a partial map of where I live. We live on Lake Erie, and the Cleveland Clinic Health System has a series of about 8 or 9 hospitals, several of them depicted here in green. We are all connected by a large group practice. We are all on the same electronic medical record. We are all on the same hospital network for the imaging component, the PACS and the RIS, and we all function with the same protocols, and we have 24-hour-a-day, 7-day-a-week, 365-day-a-year coverage by staff neuroradiologists reading scans emergently. So again, the pre-hospital care, recognition of stroke systems, establish the last known well, dispatch EMS, and then communicate with the stroke team. Let them know that somebody's coming. That means let radiology know. That means let the neurosurgeons know. That means let the neuroradiologists and the anesthesiologists know. If it sounds like it's going to potentially require endovascular treatment, call in the technologist and the nurse for the angiography suite as early as possible. You need to be able to assess very quickly via clinical exam the NIH stroke score. Systolic blood pressure cannot be too high. You can't give IV-TPA if the systolic pressure is greater than 180. You have to be sure that it's not a hypoglycemic event, and they can't be hyperglycemic because hyperglycemia is associated with a worse outcome in acute stroke. Make sure their electrolytes are normal. If they've had a cardiac arrhythmia and have atrial fibrillation and they've been on Coumadin, you want to know, well, is the INR too high so that they can't get TPA, or is the INR too low or normal, which is why they had the thromboembolic event to begin with. The aspect score we talked about briefly. This is just essentially a way of dividing up the middle cerebral artery territory into 10 different regions, the cortex, and then the head of the caudate, the insula, the internal capsule, the lentiform nucleus, developed in Alberta, and a normal score is a 10 for each of the 10 components in the MCA territory. And as you start to see signs of infarction, whether it's in the insula, the caudate, or the cortex, you subtract points for each area that's abnormal. And so when you start to get scores greater, or excuse me, less than 6, then those patients may have already completed an infarct and may not be candidates for treatment. And as I said, our network is connected across all the different hospitals. We communicate with beepers. Also, all the staff have iPhones. We have an app that connects us both to the EMR as well as our imaging system, and we can securely get the scans from virtually anywhere. Now, one of the things that struck me, I was in Italy not that long ago, and you tend to think of delivery of healthcare as, you know, the way it's always been. I grew up not too far from Cleveland, not too far from here. I've never known an ambulance or an emergency medical technician that was any different than the same ambulances and the same emergency medical technicians that I've seen growing up and throughout my professional career. But what if you couldn't have those ambulances? What if you didn't have elevators? Well, that's essentially the situation that they have in Venice. All of their ambulances are boats, and they have no elevators, and they have special gurneys to get patients in and out of the buildings, and they've had to completely rethink how they deliver emergency care. And you know what? Because time is so important, that's exactly what needs to be done with acute stroke. And this came from Dr. Hill in Lancet. Said we cannot expect the patient's disease biology to match our systems because the time window to treatment for stroke is so short. We must match our systems to the biology. And the person who really embraced this and has tried to push, who's thought outside the box and pushed the limits a little bit, is Klaus Fassbender in Germany, where he's actually helped to organize acute stroke service, and they actually have the CT scanner to determine whether it's a hemorrhagic stroke or an acute ischemic stroke in the truck. And not being too bashful, we've copied that effort here in Cleveland, and we too have an acute stroke ambulance. We don't wait for the patient to be brought to the ER. We bring the ER to the patient. And at one end, we have a portable scanner from Neurologica. We've already had 2 of these in our intensive care units at the main hospital to clinic. We simply bought another one and put it on the truck. And then we also have this telemedicine system mounted at the other end of the truck from the ceiling that has an audio-visual connection and allows, through the cooperation of the EMTs and the nurse on the truck, the ability to do an acute NIH stroke scale. We also have small laboratory capability where we can do point-of-care testing for basic metabolic panel, serum glucose, an INR in case they're on Coumadin, and so on. So here you can just see a diagram of how this is meant to work. Someone's loaded into the truck, they get baseline vitals, they're immediately scanned. Now, one of the things that we've had to work through with our neuroradiologists, neuroradiologists want scans to look perfect. These mobile scans are not perfect, but they are adequate to exclude hemorrhage or exclude a mass lesion. And let's be honest, if you get to the patient fast enough, you're not going to see an acute stroke no matter how good your CT scanner is, because CT is not sensitive. You might if it were an MR scanner, but we're not going to be putting one of those on a truck. And then you can see here in the back the telemedicine system where the neurologist is examining with the help of the emergency medical technicians doing an NIH stroke scare, and then they're transported to the facility. If it's not a terribly high NIH stroke score, irregardless of what the score is, they're going to get TPA on the truck. But if it's not a high score, they may be taken to a primary stroke center. But if it's a high score, or if we see a hyperdense vessel suggesting a large vessel thrombus on the CT scan, then they're taken immediately to a intensive stroke center where we have endovascular capability. So IV lysis ASAP, and we get the patient prepared by getting adequate intravenous access, controlling their blood pressure, again checking serum glucose, getting a urinary catheter in, intubation if necessary, although to be honest we like to avoid that because it sort of ruins your neurologic exam. So this shows on the top diagram what it was like from dispatch to pick the patient up, to get the patient to the door of the emergency room. We have very strict metrics in radiology to get a CT scan within 20 minutes. By JCO standards, it has to be read in another 20 minutes. And if they had a large vessel occlusion, then they needed to be transferred to another hospital. And by the time they got an acute intervention, it could be 4.5 hours later. That's pretty typical of those trials that I mentioned that were published earlier this year. But if you look at the mobile stroke unit, they get there to the patient in about 20 minutes, get a CT scan in 12 minutes. If they have a high score, if they have a hyperdense middle cerebral sign, they can go immediately to a comprehensive stroke center where they have IA capability, and we've gotten our times down to intraarterial treatment to 1 hour and 44 minutes. So, again, if the Venetians can do it, anybody can do it, but I think the message here is to get creative. So again, immediate and constant communication with the technologist. I'm continuing to get patients here as I'm trying to give the webinar on the patient I mentioned at the beginning, who's downstairs in the ANGIO suite as we speak. If they have a high score and no improvement with TPA, we take them to the ANGIO suite. One big question is last known well. So if their last known well is established and the stroke gets them quickly, we likely will get a CTA to document the large vessel occlusion and then take them to immediately to the angio suite. If the last known well is uncertain or they're being transported via helicopter from some very distant, smaller hospital, we may get an MRI when they arrive. We have 24-hour days, 7-day-a-week coverage. We may get an MRI to see how big the ischemic score is. And again, if the infarct on MR diffusion imaging is greater than an aspect of 6, we may or may not, likely not, treat the patient. So this is something that's evolving for us. My question for you is, currently, what are you using for acute stroke imaging? Yeah, so nobody's really using MR too much. I think we've gotten away from using CT perfusion imaging. I know in the States for a while there were a lot of concerns about the amount of radiation. We use CT angiography and CT scanning very, very, very routinely. We think it's very valuable. And we're not using CT alone. The only case where we might do that is in a patient who was picked up by the truck. You saw that there was a large vessel thrombus, like a hyperdense M1, and you've got the patient in the first hour. They're young, they've got a high NH strike score. We may just take them to the angio suite. But virtually everybody else gets CT, CTA, and if there's any question about how big the core is, we get an immediate MR as well. So let's talk then about, as we've discussed, sort of gearing up for endovascular treatment and trying to make this all happen as fast as possible and adapt to this new world. A simulated stroke intervention. We actually have a simulation center within the education building at the Cleveland Clinic, you can see here on the right, and we simulate the triage and the actual endovascular treatment for these patients as we're trying to get new team members on board. And the one thing about the 3D Systems Simulator is it not only, let's see if it not only simulates the procedure, but also the things that can go wrong. And what are you going to do in those circumstances where there's a dissection, where there's a perforation, where there's thrombosis? I mean, in the context of a very, very hyperacute and serious problem, whether it's an ischemic stroke or a subarachnoid hemorrhage from an aneurysm, I think one of the things as we try to train our fellows who come from both neurology, neurosurgery, and neuroradiology to get them to adapt to doing these procedures is to think ahead. What are the maneuvers that you can possibly do to get out of such a horrible problem should you be faced with one of these complications? And to their credit, 3D Systems / Symbionix has built in a lot of nuance. It's just not all about pushing the catheter. It's about watching the blood pressure, watching the heart rate, and having to be able to deal with these kinds of problems should they arise.
Okay, so thank you very much, Dr. Masaryk, for this outstanding talk. And I hope you all enjoyed it as much as I did. And now we would like to present a video demonstrating the stroke intervention case using the ANGIO mental simulator. And I would like to ask you, Dr. Masaryk, if you would be kind enough to guide us through the procedure.
Sure. Okay, so here you have an example of the user interface where the user selects the catheter and guide wire, and then you're presented with a display and a series of controls at the table side that looks exactly like what you would expect in the angio suite, all the way down to the hemodynamic display that you see at the bottom. So there's a guide wire now crossing the aortic arch in the LAO position, vertebral catheter, the wire is withdrawn, catheter is rotated towards the operator and pulled back. And as it straightens, you see that you're in the innominate artery, and you pull a little farther, and that should be the left common carotid. So you notice here that the operator is selecting to give heparin. And the guide catheter is advanced up over that. Initial injection of contrast and then roadmap so that one can direct the wire and then the catheter into the internal carotid artery. So advancing the 5 French vertebral catheter and then over that the guide catheter. So now an AP and lateral angiogram. And you can see that the carotid terminus is occluded. That's a bad problem. Notice in the lower right complication status, it's possible to turn the complication status on and off so that initially you can let the operator get used to the system in the same way that you would an angio suite. So now you have a microwire and a microcatheter advanced over that under roadmap guidance. Both in real life and here, this is where things get a little tricky because without contrast, you're road mapping a little blindly. But you want to get back beyond where you think the occlusion is. Document that with a small injection of contrast material so that you're past the clot. Advance the catheter here, take the wire out. There we go. And now inject a little bit of contrast material to document that the vessels are there beyond the occlusion. So once you have your catheter in place, now you can select a mechanical thrombectomy device. So you place that out just beyond the distal marker, and then while fixing that, essentially unsheath the stent triever. These are typically made of nitinol, and you'll be able to see it faintly, at least under fluoro, in the middle cerebral segment to the supraclinoid segment of the left carotid. You'll see, because it's nitinol, it will self-expand, and you'll see the tines of the stent as you unsheath it. So you can kind of vaguely make it out, and it gets wider. And then a timer starts, because again, these work essentially by engaging the thrombus or letting the thrombus come in through the tines of the stent and then pulling them out as though the thrombus were inside a basket. So here this is a balloon guiding catheter which has been inflated so that as you're pulling down, if things do break free from the stent triever, you can aspirate all that debris out of the carotid system. So now it's being withdrawn. You want to keep the distal marker of the catheter beyond the proximal marker of the stent. Okay, so re-injection, you can see that the anterior cerebral open and the supraclinoid carotid open, but the M1 is still occluded. And this is pretty common in day-to-day practice. You may get a significant amount of the thrombus out, but not all the thrombus. So now we're going to put the microcatheter back up, out the middle cerebral. Document that you're past the occlusion. Pick the thrombectomy device, unsheath it under fluoroscopy, and again you'll get the timer reinforcing the idea that you need to let that sit there in order to grasp the thrombus. And then after 5 minutes, inflate the balloon, advance the microcatheter up past the proximal marker where the stent is fixed to the stylet. Like that. And then while aspirating on the balloon catheter, pull down, take all the debris out. Deflate the balloon, inject, and you can see terrific reperfusion.
Great. So thank you very much, Dr. Masaryk. And okay, so now it's the time to answer some of your questions. I think the first one that would be very interested from our side is to hear how do you use the simulator in your training program?
So we use it two ways. As I'm not sure how it works elsewhere, but in North America, medical students finish in June and they start their internships and the residencies July 1st. So it's absolutely the worst time to be a patient in North America currently. And we have nowadays several days, maybe even a week of indoctrination, how to use the electronic medical record that we do, how to make sure that everybody's certified for basic life support, advanced cardiac life support, and radiology, how do you use the IT systems in radiology, on and on and on. So as part of the training for the new trainees in stroke neurology and the cerebrovascular fellowship and the endovascular fellowship and the cerebrovascular surgery fellowship, we go through some of these things like all the key performance indicators, last known well, presenting NIH stroke score, aspect score, on and on and on, so that when they get thrown in, all of that's reinforced and they can communicate effectively the minute that they're on call. And as the sort of focus and highlight of that, we use the simulators to sort of essentially simulate the most serious cases, which is what they're going to experience here. Beyond that, for the endovascular fellowship, we take trainees from a variety of different disciplines: neurosurgery, neurology, neuroradiology. The neuroradiology folks are pretty good at fluoroscopic anatomy, and depending on where they train, some of them have pretty good catheter skills. They're not so good when it comes to those clinical aspects that I just mentioned, and we oftentimes have them spend a bit more time in the neurologic intensive care unit the first few months that they're here. But the neurosurgery and the neurologist, they have virtually no experience running a fluoroscope, let alone a biplane angiography system, no experience catheterizing the brachiocephalic vessels with fluoroscopy under fluoroscopic guidance, no idea how to use road mapping, let alone doing the procedures and becoming fluent enough to adjust to complications. So we, after the initial introductory indoctrination in July, we moved the portable simulator to the endovascular fellows room, and then we use that as a teaching tool especially during the first year for the first-year fellows, because honest to God, they really need it. It's you know, they just, it's amazing how inexperienced some of them are. So it's really been a great teaching tool for them.
Great, so that's nice to hear. And another question we got from the audience is, what's the impact of the simulator?
Well, I think familiarity. I think that, you know, they have modules for, you know, you can use it to practice conventional angiography, how to do the right views, how to get the right pictures, the right level of magnification, the right frame rate. They have modules to do carotid stenting, which are very good. They have modules for endovascular treatment of acute subarachnoid hemorrhage and intracranial aneurysms. And they also have modules for the current endovascular treatment of stroke using stent retrievers. So I think, you know, the impact has been, and I think I noticed this today working with a new fellow, that, you know, I can get pretty impatient waiting for the fellows to, you know, put the catheter where it's supposed to be. Something that takes me seconds to do seems to take them forever. It drives me crazy. But they can get that familiarity without having to practice on a patient, and at their pace, at their leisure, you know, they have the ability to just practice over and over again, where, you know, especially early on, you know, maybe they shouldn't be practicing on a patient.
Yep. So, and one last question from the audience. Earlier you talked about the mobile stroke unit, and we got a question. With the advent of mobile stroke units being researched and worked on currently in Houston, are we
Yes.
looking at a time where we will completely bypass IVTPA and run straight to angio suite for IA
No,
procedures?
no, no. Because I think you could maybe shorten things up when you get to the hospital, um, by maybe not doing as much imaging when you got here if you saw the patient right away. But I don't ever foresee giving up IVTPA. I don't see that happening. Here's another reason why. And so we've got experience with maybe 225, 250 mobile stroke patients. And I've reviewed the CTs on the first 200. And this is what I've seen. What I've seen in a significant number of patients who present with very high NIH stroke scores, where you would presume person is going to need thrombectomy. They're going to need a stent retriever. By the time they get to the angio, and it's documented on a CTA, it's documented on an MRA when they get here. By the time they get to the angio suite, it's lysed and the vessel is completely open. So here's my theory. This is just a theory at this point on why this happens. And again, you have to remember that a lot of these patients have atrial fibrillation, and you know, you tend to think that the thrombus might be a glob or like a pebble. But in fact, fibrin clot is very stringy. And what I think happens is that someone has an embolus and it's this long string, and it gets stuck at various bifurcations, either in the carotid or at the turns of the siphon. It gets stuck, and they present with symptoms. But then the clot gets washed downstream, and ultimately that string telescopes up and gets bunched up like a string being pushed from both ends at the M1, M2 junction at the middle cerebral bifurcation. And at that point, it's completely occluded. Prior to that point, as a string that's maybe not completely bunched up, that's hanging or in that vessel as flow goes by. If they're getting IV TPA, there's TPA flowing past that string of clot the entire time. And I think in some of those patients, IV TPA actually works to lyse it. One of the reasons that IV TPA may not work is that when it finally dislodges and lands as a saddle embolus and gets bunched up, the clot no longer has TPA covering the surface of the entire clot. So I think, I don't know if, I hope that makes sense to the audience, but I think that prior to that happening, that telescoping up of that clot and producing that acute occlusion, that there's benefit to be had. And I think we're seeing that with the mobile stroke unit. So I would not deny the potential benefit of that IV TPA to anybody. And it doesn't preclude you from doing virtually anything in terms of endovascular treatment at that point.
Okay. So thank you. I think it's time to conclude our webinar now. And once again, thank you very much, Dr. Masaryk, for your talk. And thank you all for joining us today.
Thank you for having me.
So just to let you know, the webinar was recorded and will be available online in our website soon. And it's a good time to let you know that we will soon have another webinar, this time on aortic intervention. And I hope it will be as interesting as the one we just had. So of course we will update you with all the details in the next few weeks. And we really appreciate if you take a few moments to fill a short survey that will be shown right after we end this webinar. So again, thank you very much everyone, and see you next time. Bye-bye.